Good afternoon. We're waiting on one commissioner, so we're going to delay the start of our meeting just a few minutes. Good afternoon and welcome to the Wednesday, September 24th Douglas County Board of County Commissioners work session.
Is that, is that echoing? I'll get it. I'll get it.
Having a little bit of a stadium effect here in the county commission meeting space. So today we're having a work session on zero suicide. Um, this is a work session. As with all of our work sessions, there are no decisions being made. They're for informational purposes only. We welcome public comment if you'd like to make public comment on this item. We don't take public comment during our work sessions, but we welcome you to join us at our 5:30 business meeting and share your thoughts at our general public comment period. With that, I'll turn it over to Bob Tryansky to get us kicked off on our study session. Hi, Bob.
Hello, commissioners, and good afternoon, everyone. Bob Transky, Director of Behavioral Health for Douglas County. We thought that, and my apologies for being virtual, this is day 5 coming out of my COVID cocoon. We thought that given the fact that this is September, it's Suicide Prevention Month, and this is a topic that we have not shared a lot with the commission in recent time, that this might be a great time to give you kind of a full update and overview of the work that's being done in Douglas County by our partners led by public health to address the serious health concern of suicide in Douglas County. As everybody knows, but I'll just kind of refresh your memory, addressing suicide prevention is one of the 4 key objectives in the CHIP. We have set an overall objective of decreasing the age-adjusted suicide mortality rate from 14.3 per 100,000 people to 12.8 by 2029. This is an extension of an objective that was in the previous community health improvement plan. This time in this iteration, we've really gotten a lot more granular to identify what are the indicators of progress that we would be looking at to tell whether progress is being made in Douglas County. So those elements are to decrease the overall age-adjusted suicide rate, as I said, but then also to look at the number of emergency department visits that involve a suicide attempt and reducing the percentage of people who died by suicide who were seen within the prior year by a healthcare provider in a zero suicide agency, one of our healthcare partners who has agreed to implement zero suicide across the system of care. We've identified 7 strategies to go about doing that. And what we want to do today is to give you a little bit of an update on the progress that's been made on achieving those 7 objectives. This is an issue that when I started in this role in 2018, I was surprised by how serious an issue suicide was in Douglas County. Back in 2018, just to give you some historical context, when we were starting to gather baseline data about our crisis system, there were some numbers that were really interesting to me that the public health folks encouraged me to kind of learn how to help people visualize what some of these numbers mean, because we talk a lot about statistics. So in 2018, there were about 40,000 visits to the emergency department at LMH in that year. If you think about that, that's kind of like a KU football stadium filled on a good football day. It's a lot of people. And out of those 40,000 people, about 4,200, about 10% of them were going into the emergency department in the midst of a behavioral health crisis. That's like 2 nights of a sold out audience at the Lead Center, if we're trying to put into perspective the number of people that are impacted by this issue and how this plays out. Out of those 4,200 roughly people who were in a behavioral health crisis in 2018 in the emergency room, about 1,100 of them were experiencing suicidal ideation or had made a suicide attempt in the course of that visit. That's the population of Lawrence High School, a little smaller than the population of Lawrence High School in terms of numbers of people. About 750 of those individuals were experiencing suicidal ideation. About 319 people had made a suicide attempt. That's kind of half the population of a middle school building. But one of the statistics that impacted me and really got me sort of hit me was that 123 of those visits in 2018 were with people who were younger than 19 years of age. I give you that context with where we were in 2018 because this made it clear that suicide was a serious issue that needed attention and needed to be addressed. Over the previous 20 years, the suicide mortality rate in the state of Kansas had increased by slightly more than 40%, but in Douglas County, the suicide mortality rate had increased by 84%. So Public Health is going to share some information today, and we're going to show you some statistics, and the team from Public Health are going to give you, I think, a really good understanding of where we're seeing change, where we're seeing signs of hope, and where the elements of concern lie when we're thinking about addressing suicide and preventing suicide and intervening early when somebody is exhibiting signs of suicidal risk or suicidal ideation. I wanted to start this afternoon with a really brief video clip, a digital story that was produced by one of our peer fellows in a digital storytelling workshop that happened in June, and we just actually completed the second round of this today. Because this is an issue that touches individual people, a lot of them, in really significant ways in our community. And I thought this story that was produced by Eugene, one of our peer fellows, really kind of demonstrates how suicide is an issue that touches everyone.
In my peer group, I heard many heart-touching stories connected to surviving traumas. I'd say to myself and others, I've never experienced trauma. In one session, an individual in the group said, Eugene, think about it. You were 8 years old, and you had to deal with your mother in one breath loving you with all of her heart, and in another instance being gone for a matter of weeks at a time. For an 8-year-old, that has to be traumatizing. Until that time, I never recognized my own trauma. This carried forward into another important moment in my life. No more every other weekend. No more truancy reports. No more unnecessary asthma attacks. Those were the words that were in my mind when the judge granted me full custody of my then 9-year-old son. After that, there were months of smiles and a sense of calm and peace. Trenton was in my home as a happy camper full of cheer, antics, and growing curiosities. I continued to work long hours and long weeks, always hearing the question, Dad, why do you always work so much? With me, always replying, I'm doing what dads do. After years of that repeated process, I received a call on the phone saying that Trenton was in the ER due to an attempted suicide. I made it to the ER and saw Trenton in nothing but a gown, head down in shame. Why, I asked. With hesitation in his voice and a short pause, he looked at me and said, at night, I can't sleep because I lay awake wondering why my mom didn't love me enough to take care of me. I understood that. I felt that way when my mom couldn't take care of me. He went through years of neglect, and that was why I fought so hard to get him. That's why he wanted to know why I worked so much. I failed to see the trauma that he was living with, but we came up with a plan after that. And now he sleeps well at night. Now, sometimes out of nowhere, I say, hey, Trent, how's it going? How are things today? I now know that love takes more than just loving.
So I just wanted to set the stage because I think this is an issue that is an example of where all of us in Douglas County have shared concern around this issue, and it's led to having shared purpose among our healthcare partners, our partners in the education space, and community members to do what we can to reverse reversible trends, and in a community of our size to say suicide is preventable and we should be aiming for zero suicides because one suicide in a community of our size is one too many. I'm going to turn it over to Jonathan Smith to introduce his team and to share this really great information and the work that's being done in this space, thanks to their leadership.
Thanks, Bob. Evening, commissioners. Really excited to be here. And as I was walking up, I realized that the last 3 times we talked to you about zero suicide, one was back in June of last year to talk about shifting that funding of leading suicide prevention via suicide from headquarters to Lawrence Douglas County Public Health, and then the last 2 budget cycles. So we're not going to talk about money today, so that's good. I'm actually really excited to see, it gives you all an opportunity to see those decisions that you made throughout these last couple of years, the work that's being done. You're also going to learn a lot about what does suicide look like here. And then Dee's gonna, and Sarah will also talk about the Suicide Fatality Review Board. That is a Douglas County Suicide Fatality Review Board that we're really excited about. So I'm also excited that I'm the one who's not gonna do a lot of the talking today. I'm just here to be their cheerleader. So I'll pass it on to Dee, and then Sarah, go ahead and introduce yourselves.
Okay. Hi, I'm Dee Kynard. I am the informatics manager at Lawrence Douglas County, and I look at data. That's what I do. So I started this work in 2015, maybe, starting to look for data. That's when the health department asked KDHE to give us death certificate data, and then also KDHE made available to us Essence, which allowed us to look at a de-identified data set from emergency department visits. So it gave us a lot of information that we never had before so that we could write and analyze data at the county level. So we had a 2019 suicide report, and in a few weeks, we're going to have a 2025 suicide data report. So you'll have all of this information for you. You can look at this information later. So I'll pass it on to Sarah.
Hi, I'm Sarah Landry. Oh, there we go. Okay. Okay. First time here. Thank you. Can you hear me now? So I'm Sarah Landry. I'm the Zero Suicide Coordinator. I've been in this role for just 7 months last week. So my background is in social work. I've spent most of my career in community health. But about 5 years ago, found my way to suicide prevention work. I became a trained volunteer crisis counselor through headquarters. Really enjoyed that work. It was what I could do when I had time. And then with this position opening up, I get to do what I'm passionate about full time. So excited to be here and share information about zero suicide.
While you guys are queuing that up, I just wanted to ask, maybe Sarah, you know this. KBI was one of the places she mentioned recovering information or accessing data from. What are the other data sources that you all are able to pull from?
I'll let Dee field.
Okay, I'll just wait in the question. Sorry, it was me trying to fill the space while the question was top of mind, but I'll make note of it.
Okay, so as we said before, we're talking about zero suicide in Douglas County. And so what I will be presenting is some information about suicides and also suicide attempts. And so as Bob So as Bob said, suicide is a public health problem in Douglas County. So why do we think that? Part of it is that in order to understand why we think it's a suicide, a public health problem, is that we want to talk about what the data tell us. And when I talk about the data, what I'm talking about is death certificate data and essence data. And essence data is the de-identified data set that I talked about earlier that gives us information about emergency department visits. And so what I'll be able to tell you about today is who is dying of suicide in Douglas County, how these people are dying of suicide, who's attempting suicide, how they're attempting suicide, and then how things have changed over time. And then Sarah's going to go into more detail than I am about, what we're doing about this. I'll talk a little bit about this. As Jonathan said, I'm real excited because we have a new data set that will have more information about later, but we're working really closely with our coroner scene investigators. We're so lucky in Douglas County because we have a professional team here, a professional team here, and they have reports that we've been using for some time, just monitoring them. But now we're using them in our suicide fatality review board. And what that's going to allow us to do is look at the circumstances surrounding suicide so that we can come together as a community to find different and new community-based prevention projects. So this has a lot of potential. We just started it last week, and we'll have our first review in October. So suicide, as you heard in the video earlier, has an impact on communities. National data tells us that 4 in 10 Americans know someone who has died of suicide. And as you know from the video, it touches friends, it touches families. I don't have to tell you this. You probably know this from personal experience, but that it just affects people who go through this, but then the people who help them, it's a whole emotional cascade. And so it creates just, it affects our emotional health of our community. So when we look at this, 42%, 42% of people know someone who've died of suicide. And among those who've reported suicide ideation, about half, about 57.9% of people know someone who've died of suicide. So a lot of people know someone who has died of suicide. And so another way of to look at the impact that suicide has on our community is to look at suicide as a leading cause of death. This is the latest information that we have from Douglas County. We, in order to look at suicide, the leading causes of death for different ages in Douglas County, we have to look at 10 years of data. So this is 2014 to 2023. And as you can see, suicide is the second leading cause of death for those 15 to 44, the 7th leading cause of death for those 55 to 64, and it's the 8th leading cause of death for all ages. What's really important to know here is that in the US, suicide is not one of the 10 leading causes of death. So it is in Douglas County, but not the US. So
Can I ask,
Yes.
what about the state of Kansas? I know there's, it tracks with agricultural communities having larger rates of suicide. So how do we compare to the rest of Kansas?
we have a lower rate of suicide than the state of Kansas, but it's not statistically different. So that's the good news. That's one of the good news. Oops. Here we go. Okay, when we look at the Kansas Communities That Care survey data, the latest data that we have from this survey is 2022 because we don't have enough students who participate in it. But in 2022, more than a third of Douglas County 12th graders had serious thoughts of killing themselves sometime in their lifetime. And then when we look at our rates of suicide in Douglas County, this is looking at We look at 5 years at a time so that we can get stable rates. So this is looking at our suicide rates from 2000 to 2023, which is our latest death certificate data. And as you can see, our healthy 2030 healthy people suicide target is 12.8. That's our target for the health plan. And you can see that in 2000 to 2004, we were way below that target. And so in 2019 to 2023, we were 14.8. Now, what this says to me is, and as you can see here, is that our suicide rates go up and down. So they're not just going straight up, but they go up and down. But what is important to know here is that if you look at 2002 to 2006, you can see that that dot, the third dot from the left, is below the suicide target. In that 5-year period of time, there were 57 suicides in a 5-year period of time. That translates to about 11 to 12 suicides a year. In our latest time period, the 2019 to 2023, where the orange dot of 14.8, we had 90 suicides. That translates to about 18 suicides a year. And then if we look just at 2023, we had 25 suicides, the highest number of suicides we've ever had in Douglas County before. So when I look at the coroner data, so in death certificate data, the last year of death certificate data that I have is 2023. We have coroner data for 2023 and 2024, and it's a partial 2025. But in 2023 and 2024, in our coroner data, we had the same number of suicides. So we have a lot of work to do in terms of preventing suicide. Now, figure 3 here, what this graph shows us is that, as you heard in the video, and as all of you know, suicide affects all people, all ages. And so on the left-hand side are the percent of suicides by different age groups, 3 age groups, and on the right-hand side are the percent of the population. So what this shows us is that the 25 to 54-year-olds are disproportionately affected. They account for 56% of the suicides, but 40% of the population. So almost 90% of the people who die of suicide are white non-Hispanic. So 88.9% of our suicides are white non-Hispanic. Most of these folks are males. So males account for just over 3/4 of our Douglas County suicides, so 78%. And on the right-hand side, you can see that of the males who die of suicide, 57% use a firearm, 27% suffocation, and almost 6% poisoning. And over to the right, you can see that there's a different pattern for women or females. So 35% use poisoning or suffocation, and 25% firearm. When we look at ages overall, you can see that firearms are the most common external cause for suicide for all ages, but especially for people over 65 years of age. So you can see that 70.8% of 65 and older use firearms, and most of this is driven by men. So what about suicide attempts? These are suicide attempts in the emergency department. So females account for almost 2/3 of Douglas County suicide attempt visits, so 62%. So unlike suicides where that's a male phenomenon, suicide attempts are more often female. And this shows some change over time for males and females in the emergency department. These are emergency department visit rates for suicide attempts from 2018 to 2024. And what you can see here is that for both males and females over time, we have decreased rates of suicide attempt visits. And probably more, and it's actually more of a decrease in females than in males. But what's really interesting to me is that females have always been higher or more often treated for suicide attempts than males. But that gap has closed just recently. It's curious. I can't really explain it exactly, but the trend is good. What I'm thinking that this is due to is that all the different changes and improvements we've made in the crisis system, we've seen a change and a decrease in the number of behavioral health visits over time go down in the emergency department. And this is just part of that same trend. So this slide shows from 2019 to 2023, shows suicide attempt rates in the emergency department by age and by sex. And what you can see here is that for both males and females, the higher rates are in the 10 to 19-year-olds, and that the 10 to 19-year-old female rates are much, much higher than the 10 to 19-year-old male rates. But if you compare the female rates to the male rates, almost at every age, they have higher rates. But if you look over at the male column, the 10 to 19-year-old male rates are higher than any other male rates. So we can't forget about the young males, but the young females are at much, much higher rates than anybody. This slide shows the change over time between two time periods, 2018 to 2020 and 2022 to 2024. And as you can see, the decrease, the 10 to 19-year-old emergency department visit rates for suicide attempt have gone down over time dramatically, but still they're at higher rates than every other age group. And what we can see here is that the 10 to 19-year-olds, the 20 to 29-year-olds, the 40 to 49-year-olds all decreased significantly, and that the other age groups did not decrease significantly. But the 65-year-olds are less likely to be treated in the emergency department for suicide attempts, but their rates have actually gone up significantly. So something that we have to pay attention to. So not surprisingly, both males and females, the top bar of females and the bottom bar of males, when they are treated in the emergency department for suicide attempts, it's most often because of poisonings, followed by cutting and piercing. And then the other mechanisms, it's a combination. No one category actually was large enough to graph, but what we're looking at here is a combination of poisoning and cutting, so two things, or burns, or suffocations, or maybe hitting something against themselves. The gray bar is curious because it's an unspecified bar. And why do I say unspecified? There is a code in the emergency department, an ICD-10 code, that is an unspecified suicide attempt code. Often when we see that code, there's another code also that tells us how, so poisoning or cutting. These are cases where it's just an unspecified code and not another code to tell us how. So they're suspect cases because I'm thinking that in the emergency department, they know what they're treating. So that's a little bit, I don't know what to do with that. They're seeing this at the state level and they're going, I don't know what to do with this. So it's a coding issue.
Dee, I have a question for you.
Sure.
I guess I don't know if you'll know this, but in the emergency department, and you just described that they have codes that they're inputting, which is something that you're able to see, that de-identified data set you told us about. Do you know what their criteria is for, I guess, coding something as a suicide attempt versus, I'm thinking about cutting or piercing, that those are common self-harm.
Mhm.
Self-harm does not always equal
Right.
suicide
Mhm.
attempt or ideation. So do you know anything about the process for
Yes.
how that's being determined?
Yes, yes. In fact, there is a code for self-harm, and we excluded those from this analysis. So you're right. They're not, it's called non-suicidal self-harm,
Got it.
and we excluded that from this particular.
Presumably something about the disclosure from the patient or information gathered is going to indicate that
Mhm,
distinction for them. Okay, thank you.
Exactly. So social isolation is one of the strongest and most reliable predictors of suicide ideation, attempts, and lethal suicide behavior. And so among men, deaths due to suicide is associated with social isolation and other indicators such as living alone. And about 25% of men in Douglas County live alone. So we do have a lot of social isolation in Douglas County, really in the US. So social connection could be a protection. So what we are looking at with zero suicide in our approaches to prevent suicide and suicide attempt is just a way of providing safer suicide care and a way to connect with people, to give them that connection so they don't feel so isolated. And so what Sarah's going to talk a little bit about is how we connect with people and how we try to keep people safe with zero suicide.
Okay. So what I just handed you there, as Bob mentioned, it's Suicide Prevention Awareness Month. So this is our attempt to get some kind of community-facing information out there about what zero suicide is, and also indicate who our partners are in this work. So Dee and Bob did a great job setting kind of the historical context, the data context that we find ourselves working in. So I'm going to switch gears a little bit and talk about what zero suicide is, why it matters, and what we're doing since I've been here in this position to kind of build the foundation to support this work countywide. So to start, I want to show a quick 3-minute video. It's produced by the Zero Suicide Institute, and it does a really great job of describing what zero suicide is from that 30,000-foot view. So we'll take a minute to watch that. And did you put the volume?
Every minute of every day, suicide impacts the lives of hundreds of people across the globe. It robs families of loved ones, young people of their future, workplaces of colleagues, and communities of their most valuable resource, their people. And surprisingly, of the 800,000 people a year worldwide who die of suicide, most saw a healthcare professional in the year prior to their death. Contrary to popular belief, the problem isn't that those at risk are disconnected from healthcare. It's that gaps exist that allow these individuals to slip through. Despite this, healthcare has remained unchanged, presuming many deaths were tragically inevitable. Inspired by the Henry Ford Health System in Detroit, Zero Suicide is a call to action based on the belief that no suicide is fated. It all starts with zero because a radical and systematic approach to perfection is the only way to create dramatic change, and it must be driven by leadership's commitment to creating a new culture around suicide prevention. 3 specific evidence-based interventions have emerged as central to zero suicide, creating the multi-layered approach that helps ensure no one slips through the cracks. First, We must make it okay to talk about suicide. Healthcare must routinely screen for suicide risk at all patient touchpoints within a health system. Simple screening questions like, do you have thoughts that you'd be better off dead or hurting yourself, allows healthcare professionals to start a conversation about suicide, create a connection, and acknowledge the anguish and pain. The simple act of asking about suicide risk is more predictive of a future suicide attempt than even cholesterol scores are for a future heart attack. Second, the strongest resource in preventing suicide is always the person at risk. By collaboratively designing safety crisis plans that include reducing access to lethal means and following up with phone calls after discharge, one recent study showed a 45% reduction in suicidal behavior. And third, we must treat suicide directly. We've assumed that treating mental health and/or addiction will fix suicide risk, but that doesn't always remedy the pain that underlie thoughts of suicide. Zero Suicide trains health professionals to deliver specific treatment, as well as caring and supportive contacts, either between appointments or as post-care follow-up in the weeks and months to come. This relentless pursuit of perfection and insistence on evidence-based intervention works. Henry Ford saw a dramatic 80% reduction in suicide and maintained that success over a decade, including 1 year when they actually achieved zero. And at Nashville-based Centerstone, one of the largest nonprofit community mental health programs in the U.S., they reported a 64% reduction in suicide deaths since implementing these initiatives. And on the other side of the world, Gold Coast Health in Queensland has succeeded by utilizing the resources of the Suicide Prevention Resource Center, including a specific toolkit with a set of practices and resources for data collection and continuous quality improvement. Additionally, thousands of other organizations around the world are now taking their first steps towards zero suicide. Bold visions have put a man on the moon and cured polio. For suicide prevention, there's no more time for half measures and missed opportunities. Only with insightful leadership committed to the pursuit of zero suicide will we be able to make significant strides towards eradicating these tragedies. Zero suicide, healthcare that believes no one should die alone and in despair.
Okay, so I, oh shoot. Do I need to turn something else on? Okay. Well, before I talk a little bit about this information here, to me, some of the important takeaways from that video are one, that suicide is preventable, and that's really the underlying belief behind this framework to begin with. And this framework is important for healthcare systems because it really does shift from a reactive kind of treating the crisis in the emergency department to a proactive practice of proactive care, and really equips staff to ask, respond, and support people as they're going through transitions of care. And as you notice, this has been something that has been implemented in multiple settings across the country and in other countries. So it really does have a breadth of evidence behind it, and has really become the gold standard in suicide care. So it's a proven framework, and that's why we believe in it so much. So as they kind of alluded to in the video, this framework was developed because so many people who die by suicide do interact with healthcare systems in the years and weeks, months before their death. So some studies here, one study found that 95% of people who attempted suicide had seen a healthcare provider in the year before their attempt. Another study found that 38% of people who attempted suicide saw a healthcare provider in the week before their death or their attempt, and 19% of people who died by suicide saw a mental health professional in the month before their death. So what this data tells us is that there's a lot of opportunity. If we can apply this framework, in national settings, that there's an opportunity to really intervene early. But it does require trained and supported staff so that we don't miss these opportunities. And so we did the same kind of look at our data locally. With our zero suicide partners that are listed on that sheet I gave you, that consists of Bert Nash, DECA, Heartland RADAC, Heartland Community Health Center, and LMH. And what we found was that in 2022 in Douglas County, 65% of people who died by suicide saw a health or behavioral health provider in the year before their death by suicide. So again, similar to national studies, that tells us we have an opportunity to intervene early, to train staff and develop systems that can lead to safer suicide care. What this also tells us is that 35% of people who died by suicide in that year did not interact with the healthcare system. So it's not just a clinical system of care, it's also the community-based prevention that we should be focused on too. And so, we really value partners like DECA and Headquarters who do a lot of work in the community-based prevention space. And as Dee mentioned with the Suicide Fatality Review Board, we're really excited about what that will produce. All of our zero suicide agencies are represented in that group, as well as law enforcement and emergency responders across the county. So we're looking forward to that work.
Of the 35% that did not see a healthcare provider, do you know what that population looks like?
I do not.
So in order to get this information, we had to do a double-blind study. And so they only answered 3 questions for me. So one was the overall, one was how many males and how many females. So that's all they would let me know. So they wouldn't let me know exactly who they were, who touched these systems.
So do you know like how many males and how many females?
50% of the males saw a healthcare provider, which I was really surprised of. And I think it was like 60% of females.
Did you know like the age breakdown?
No, I didn't. And part of that was that the partners, because of 42 CFR Part 2, did not want to identify anyone. And so because of this relatively small numbers, if they showed me or told me too much, they were afraid I would be able to know who they had seen. So there may be a way this next time, we're going to do this study again next year. There may be a way to do some breakdowns on ages so they will know a little bit more information. So this was our first attempt, and, collaboration is part of trust. And I think we've got the trust now.
Absolutely. Yeah. So then of that, I'm assuming then we don't know race, we don't know socioeconomic, rural.
All we know is that most of the suicides are white non-Hispanics, so we won't be able to break that down for sure. But we might be able to know something more about age.
Okay.
But I'm not sure we'll get much more than that.
Hey,
Okay.
Dee,
And
one other thing that struck me through this work, Commissioner, was, as Dee was saying about building trust and sharing data, the fact that the agencies collaborated on this project in ways that they hadn't before. What it does do internally, we were hoping, was get individual agencies' attention to look at the individual folks that were seen in the that they did see. So that there's an opportunity for buy-in from the agencies to say we want to try to implement our own internal QI processes, because obviously the statistics with zero suicide hold true, and there's opportunity here to build the type of ongoing work that will get us to the point where we can answer the questions with more granularity over time.
okay. And then the 35% that did not see a healthcare provider too, do we know the type or the type of suicide, right? Like, no? Okay.
But that might be interesting to try to see if we could get there.
Yeah, agreed. So that those that actually did see a healthcare provider, if we could like break that out, that would be really interesting to see the path that they went down, right? Versus those that actually did not see a healthcare provider, the path that they ended up choosing. And then those, if we could even further break down those that actually did see a healthcare provider, the type of familial connections they actually had, and then those that did not see a healthcare provider, the type of familial connections they had, if they had any community-based connections. Because even if you didn't see a healthcare provider, were you seeking any other community-based supports that were outside of a healthcare provider?
I got a question. How are drug overdoses considered that result in death?
Oh, that are considered suicide or drug overdoses in general?
No, I just meant if someone overdoses on drugs, is it ever listed as a suicide?
Oh, yes, it is. Absolutely. Yeah, we do have some. There are not as many. I mean, we had the poisonings that I showed. That's drug overdose. Mhm.
Okay, so yeah, I'm so sorry. There it goes. Okay. I'll just kind of touch base on this quickly. This is another way to kind of think about or look at suicide. What does zero suicide look like in practice? This is kind of called Swiss cheese model of accidents. It's often used in patient safety and error reduction. But what it does is each slice kind of represents a step in care, and taken together, they create a care pathway that each zero suicide organization puts into place to make sure that these steps and interventions are layered together in a way that reduces risk or serious injury and death for patients that enter care. So all of the zero suicide agencies in Douglas County use the same screening tool, which is really useful for having that common language when we're talking about level of risk. So everybody does this differently depending on the services that they provide, their workflows, et cetera. So we can kind of talk about this generally speaking. But essentially, a person experiencing suicidal behavior or thoughts might enter the system of care. They receive screening to identify if there is risk present or not. If risk is elevated, then there's opportunity to do a further assessment and identify what risk or protective factors are there, what kind of level of care might be needed. Staff can also be trained on how to provide collaborative safety plans. So if someone is in crisis or experiencing suicidal ideation, there's opportunity to talk about what kind of coping strategies might work for you, who are your support people in your life that we can reach out to, counsel folks on access to lethal means. Once those interventions are in place or have been completed, then we can refer or provide treatment for suicidal thoughts or behavior that are evidence-based and treat suicide directly. And through that whole process, the idea of making sure that there's a continuity of care, that we are making sure that people are supported, whether they're being referred from provider to provider or between organizations, is really important because we know that in transition periods, people can often fall through the cracks. So that's kind of in essence what a care pathway and what a zero suicide model can look like in an organization. It's also important to note that zero suicide at its core is a quality improvement process. We embed these practices into our workflows, and it requires trained staff. So it really is important that we maintain a level of care, and that means that we're constantly evaluating what we're doing and understanding what those outcomes look like so we can identify opportunities to improve that care, and that our practices are data-driven and continually improving. Since I've been in this role for about 7 months, our goal is to support zero suicide as a county-wide approach. But we've really been focused these past 7 months on kind of building our foundation to do this work and do this work well. So we've kind of broken it out into 3 different buckets of activities that we've really been focused on. And the first is partnership development. Obviously, that's critical to building collaboration for collaborative action. So we've reached out to all of the other zero suicide organizations that are implementing this work to begin building those relationships and trust. And as we move forward, we aim to work more closely individually and collectively with partners to improve aspects of our work together, like in referrals and transitions. That can be a common pain point in this work, and that's not just unique to Douglas County. Referrals and transitions in care are often difficult for a lot of reasons. And we also meet regularly with DECA to support other suicide prevention strategies that are in the CHIP that Bob alluded to earlier, and we very much value their partnership. We've also spent a lot of time building our own organizational capacity so that we can develop adaptive tools and processes to support sustainability and our quality improvement efforts. We want to do this so that we can kind of level up our work, but also support other agencies in doing this work and any others who might be interested in implementing zero suicide in their organizations. This framework is adaptable, and that's also kind of the beauty of it too. This has been, as you saw in the video, something that's been put in place for 20 years, and the Zero Suicide Institute is constantly learning from those that are implementing this work. And so there's always new toolkits, always, adaptive ways that this can be used in different settings beyond just healthcare and behavioral health. A few of the things that we've done specifically to build some of our organizational capacity, we had a core team attend a Zero Suicide Academy. That was a 2.5 day long affair where we really got some foundational knowledge and skills and tools to do this work. We've also have been the beneficiary of a KDHE grant for Zero Suicide. And so we have participated in statewide community of practice, where we've been able to share learning with other health systems and community-based mental health centers across the state. And we were actually selected, of the grantees, we were selected to host a site visit with Zero Suicide Institute experts. And so they came to the health department and provided a day-long process where we were able to gather staff input, examine our workflows, and things of that nature, and create short and long-term action plans. So we were able to benefit from that and have learned a lot in all of those efforts. And then the last piece is workforce development, so that we are able to train our staff, support other partners, and
Commissioners, we've lost the voice.
Looks like Commission Zoom is muted.
unmute, or
Wait, I'll do it.
We hear you now.
We can hear you now.
Okay. Yeah, the problem is we're getting quite a wind tunnel effect in here on our end. So that I was trying to fix that. I think it's the laptop, but just bear with us. We're almost done. That'd be great.
okay, I'll wrap this up. But anyway, we've been spending a lot of time developing our workforce and have capacity now to provide QPR training and counseling on access to lethal means training for our own staff partners and other community. We spent some time this morning with the Douglas County Peer Fellows doing QPR training. So in essence, we've really been, thinking of ourselves as a learning laboratory to really adapt this framework and do it well so that we can support and share learning, learn from others, and kind of build that strong foundation for long-term community-wide implementation. So here are some brief takeaways. I'll stop. But if anything from today, again, suicide's preventable public health issue in Douglas County, and there are things we can do about it. Zero suicide is a very solid evidence-based approach to doing this work when done to fidelity. And we at Lawrence Douglas County Public Health are really building the foundation to support this as a county-wide approach. And when we take that public health approach to this issue, we are able to create a community where suicide prevention is prioritized. We can coordinate our care and supports accessible and suitable to the specific needs of our community.
Thank you for your presentation. Are you or will you be tracking any like lethal like social media? So when we think about like social media nowadays, we're seeing a lot more social media that's really violent. Kids are accessing a lot of videos out there where they're seeing a lot of individuals that are physically killing themselves, and we're seeing suicides that are actually being shown live, and or they're seeing other videos from other countries. Will you be tracking any of that violence and or some of those media content that's out there that's actually encouraging other kids or adults, right, to initiate on their own, or creating these like mini collectives, right, of individuals or adults, right, to encourage self-harm?
First thing I'll say is we would probably need to find like where's a good data source for that. This is coming from a person who just doesn't even have social media, so I think we would need to first find out where would the data source for that be. Like a lot of the data that you've seen today specific to Douglas County came from our own hospital, from our own community. So I think it's definitely a good point and worthwhile researching. I think for us the homework would be where's a credible data source that we could find to begin studying that.
You kind of touched on this, but we provide funding to a lot of social service agencies, more than what's on your list of partners. Do you have plans to educate those in other groups? And I'm thinking of people who might be in stress, like Family Promise, Willow, even Holistic Defenders may run across somebody who has suicidal tendencies. I'm just wondering if there's a way to educate those folks to see what to look for.
Absolutely. That's a really great point. And, to my last mention, we did QPR with the Douglas County Peer Fellows this morning. And it was a really lively discussion with a lot of, folks talking about how much this means to them in their work and how important this is. And we actually couldn't finish because we had such discussion. And so we'll be coming back and really, drilling down more to how they can use some of these skills in their work. So I think that's a really great point. It's something we definitely have on our list of things that we want to make sure we can reach out to anyone who's interested. I mean, this is part of a framework, and but you can take these practices and teach them to anyone to make the community more safer. So.
And I would say to any other community partner out there listening, if you're interested in this, just reach out to us. Sarah is more than happy to talk with any partner in the community. It shouldn't be just limited to the healthcare providers or the service agencies that you see on there. That's one of the great things about Sarah. She's a great teacher. So if anybody else is interested, just reach out to us.
Is there anything
Commissioner, go ahead, Commissioner. I'm sorry.
Sorry, just a quick question of creating a training module for just like community groups. So not necessarily, service providers, but just folks that are a point of contact for our community.
So, I'm sorry. Can you say the first
part? I have an
part?
answer.
Okay. Yep.
Yeah, I think one of the answers is there are existing training modules and approaches that are being implemented in the community. So for example, mental health first aid, which is offered to a lot of community members over the course of the year, specifically has module and practice of how to ask the question, are you thinking of suicide? Do you have a plan? Do you have access to means? QPR is also an example of that kind of training. It doesn't just have to be delivered to service providers. It could be presented in a Sunday school class. So I think it's a question of encouraging, like Jonathan just did, our community members to reach out to the subject matter experts and pull them in. DECA can do mental health first aid, public health can do mental health first aid, Bert Nash can do mental health first aid in the QPR trainings and assist trainings. There are a number of, I think, existing modules, Commissioner Willie, that we need just to continue to bring people to them so that we continue to build on the progress that's been made.
And QPR is?
Question, persuade, refer. So it's akin to CPR. That's really what they were going for with that acronym.
One other thing I'll throw out there just about the Suicide Fatality Review Board. You've heard it mentioned a couple times. I won't take too much time on it, but you mentioned other community partners. So we just started this. We had a mock review last week, right? It was last week. So really what this is going to do in other communities where this has been adopted, let's say there are people who are committing suicide had pets. They found out that they were taking their pets to the Humane Society. So then the Suicide Fatality Review Board looked at the Humane Society as an intervention. So this Douglas County Suicide Fatality Review Board that we have specific to Douglas County, obviously given with consent from the next of kin and family, will be examining some of these cases. And then who knows what interventions we'll come up with. You know, maybe the Humane Society here, just asking a few questions can really prevent some of these suicides from happening.
Yeah, I appreciate that point, Jonathan. And to pull a little bit on the thread from you, Commissioner Anderson, I think I'm really excited about this Suicide Fatality Review Board. I know I've talked with you, Dee and Jonathan in years past, and Bob and I have talked about it, so I'm very excited about it coming to fruition. I think it's an opportunity to look at some of these influences and or risk factors. So the specific risk factor that you mentioned, I think that's a really interesting one too. You know, it may not be possible to really glean much data-rich information about, but through the Fatality Review Board, there could be information provided, you know, by way of families that reveals that some of those influences or factors might have been there, and it may not be sort of statistically significant, but could be information that is valuable. Similarly, you know, domestic violence and suicide. There's a lot of intersections there to discuss both, you know, to Commissioner Dorsey's point about, you know, individuals suffering trauma. That's obviously a risk factor, right? And in crisis otherwise. And within the context of domestic violence relationships, a question we ask in assessing a victim's safety is about whether or not suicidal expressions from the person perpetrating harm against them are present, because that's a risk factor for everybody involved. And so I think that it will be really interesting to see the different intersections that are sort of revealed through some of that more specific case data and information and context that isn't really possible to glean from de-identified large data sets, right? So that those two things hand in hand, I think, will help us zero in on some more opportunities for intervention, like you mentioned, Jonathan, at the Humane Society, opportunities that are sort of creative and informed by instances that we can recall, you know, there were these opportunities maybe, and how do we do our best to stand up some additional supports that prevent that situation from happening in the future.
So I'm excited to hear where we're going, but I wondered if we could take just a minute and look back. There's been a lot of work done in reducing the number of suicides, and I was sort of surprised to see that the data doesn't maybe is not as encouraging as I hoped. What can we learn from that?
So we did see a decrease in the suicide attempts, and I think that's why we decided that the Suicide Fatality Review Board was going to be so important, because suicide is going up really everywhere. So preliminary data in the US shows that suicide will be probably in 2024 leading cause of death, where it's not now in 2023. That's the latest official data. And so there's something going on in our country and all in our communities right now that is making it worse. And so by being able to drill down deeper, I think that's going to help us, because I really feel like in communities where they have had these suicide fatality review boards active for a while, what they have found is that from year to year, circumstances change. And so keeping your finger on the pulse is really important. And right now, with 2023 data being our latest data, that's hard. You know, we just don't have up-to-date data. So that suicide fatality review board will allow us to get more up-to-date data, so that we can maybe understand more in real time what is going on. So I think that that's one hopeful thing. So I mean, I was discouraged too when I looked at the data, because we have been doing a lot, but a lot of it's not health care. So
And Dee, I really appreciate that, because over the summer, Surgeon General released a report around social media, and you specifically honed in on girls, right? On females. And our Surgeon General specifically really touched on the fact that social media has been a real hindrance, and it is leading to depression, and it's leading to anxiety, and it's leading to girls causing other girls to question their own body image, and to lead to other girls bullying girls, and to leading to boys, right, no longer really having a safe place for boys to really uplift other men. And as we think about social media, I think that is potentially a place where we could lean in and really understand if that is truly a driver in our community. Our Surgeon General stated that it could be seriously a driver for suicide ideation and for our increased rates of suicide. And so that could be a serious driver here in our community across Douglas County. And one of our ways to mitigate risk could be removing phones from our schools. When you walk in the door, when you go to school, placing that phone in a basket and not having phones in our schools. So there are many ways from a policy perspective that we could reduce that risk, and then allow our children, our youth, to actually have the opportunity to be educated without having that distraction.
Commissioners, any other questions? Well, thank you all for your presentation, for sharing, and Bob, thanks for being online and not here in person. We appreciate it, and thank you all, and we will adjourn until our 5:30 business meeting.